Hypertension, the silent killer. So today we're going to talk about high blood pressure in the setting of ambulatory care. So I know in the hospital, blood pressure control is a little bit different. It's kind of hard to catch on to, but this is ambulatory care, so your PCP blood pressure goals. So firstly, we're going to define high blood pressure based on the ACCA/AHA 2019 blood pressure hypertension guidelines. So what is normal blood pressure? It's less than 120 systolic over less than 80 diastolic. What do you do for it? Absolutely nothing, because you're doing fantastic. Yay! So elevated blood pressure is the next stage, and this is 120 to 129 over less than 80. What do you do for this? Non-pharmacological therapy. So weight loss, diet, exercise, watching your sodium intake, etc. So now we're moving into actual hypertension. So stage 1, it's when you have a blood pressure of 130 to 139 over 80 to 89. And what you do for this depends on your ASCVD score risk. If it's greater than or equal to 10%, then you're going to go with blood pressure medications. If it's less than 10%, then you'll go with non-pharmacological treatments, which we talked about in the prior on the elevated blood pressure. So diet, exercise, weight loss, sodium restriction, etc. Hypertension stage 2 is when you have a blood pressure greater than 140 over 90. For this, you're going to get antihypertensive medications. So which ones do we pick? I mean, there's like a million, right? So based on different demographics, patient populations, you start with different blood pressure medications. So this is taken from the JNC 8 that was published a couple of years ago, basing populations, blah, blah, blah. So if you're non-black and less than 60, first you're going to start an ACE or an ARB. You have high blood pressure, start an ACE or an ARB. You don't start them together, it's one or the other. Usually you start with an ACE inhibitor, and if you get that cough from the bradykinin increase, then you'll switch to an ARB. So ACE inhibitors are like lisinopril, ramipril, and ARBs are like losartan. So if that doesn't control your blood pressure, you can add a calcium channel blocker, specifically DHP calcium channel blockers, not non-DHP calcium channel blockers. So we're not using diltiazem or verapamil. That's more for like AFib and rate control. So we'd use like amlodipine or nicardipine or something along those lines, the ones that end in pine. So if you're still uncontrolled despite using an ACE or an ARB calcium channel blocker, you can add a thiazide. So this would be like chlorothalidone or hydrochlorothiazide. So next category is if you're non-black and greater than 60. It's a little bit different. The first drug you'll try is a calcium channel blocker or a thiazide, so one or the other. Second drug you'll pick, if their blood pressure is still uncontrolled, is if you chose a calcium channel blocker, for your first one you could do a thiazide or an ACE or an ARB. If you chose a thiazide, then you can do a calcium channel blocker, an ACE or an ARB. Third line, if still uncontrolled despite using 2 other medications, you'd use all 3. So an ACE or an ARB, calcium channel blocker, and a thiazide. So if you're African American, it's very similar. So first you do either a thiazide or a calcium channel blocker. Second line is either whichever one you didn't choose, calcium channel blocker, thiazide, or an ACE or an ARB. Third line is using all 3 again, calcium channel blocker, ACE inhibitor, ARB, and thiazide. So diabetes. So if you have diabetes, you want to start with an ACE inhibitor or an ARB. If you're African American, it trumps this, so you'd use a calcium channel blocker or you'd use a thiazide. Same for second line. If you have diabetes, you'd go with you already have an ACE inhibitor or a ARB, so then you'd go with a calcium channel blocker or a thiazide. Third line, you would go with all 3 agents, so an ACE inhibitor, an ARB, a calcium channel blocker, and a thiazide. Are you noticing a trend? yeah, so I'm about to ruin this trend in a couple demographics, but next is CKD. So if you have CKD or chronic kidney disease, you'll start with an ACE or an ARB because ACEs have kidney protection. And then you would go to a calcium channel blocker or a thiazide. And then third would be using all three. And I don't know if I stated this already, but you never use an ACE and an ARB together because they basically work on the same system, the RAS system, the RAAS. It's like renin, aldosterone, angiotensin system. So don't use those together. It's either one or the other. So, like I said, CKD, use all three, third line. CAD, so coronary artery disease, you would use a beta blocker. Ooh, no. Because it helps with remodeling of the heart. So does an ACE inhibitor. And then, so you'd use a beta blocker or an ACE inhibitor as first line. Second line, you'd add a calcium channel blocker, thiazide. Third line, all four. So a beta blocker, a calcium channel blocker, an ACE or an ARB, and then a thiazide. Same with a stroke. You'd start with an ACE inhibitor or an ARB, move to a calcium channel blocker or a thiazide, and then if it's still uncontrolled, you do all three again. So ACE inhibitor, calcium channel blocker, and thiazide. Now for congestive heart failure, you're going to start out with three. ACE inhibitor, because it helps with the remodeling of the heart, a beta blocker, and a diuretic. Now diuretics are more for the edema symptom control, but it also lowers blood pressure. Now if those three are not controlling your blood pressure, you can add a calcium channel blocker or an aldosterone antagonist like spironolactone. Third line would be adding the one that you didn't add previously. So that is hypertension guidelines in a nutshell. A lot of words were said, but I hope it was a good refresher. I think the most important thing to remember is ACEs and ARBs come first in CKD and diabetes because they have kidney protection. All right, ciao.